finally, we sit down with Dr. Suresh Ramalingam, who is the Deputy Director of Winship Cancer Institute at Emory University, to share his insight on a handful of the lung cancer studies being presented at the ESMO Congress this year. Hi, Dr. Ramalingam. Thank you so much for being here today.
Thank you for having me.
Great. So you are presenting the analysis of the FLORA trial looking at acquired resistance mechanisms to frontline osimertinib in EGFR mutant non-small cell lung cancer. So what do we know now following this study?
Absolutely. As you know, the FLORA study has already led to a new standard of care in frontline treatment of EGFR mutated lung cancer. Osimertinib is now used in the frontline setting. Then the key question is, when patients develop acquired resistance to osimertinib, what are some of the mechanistic aspects behind it? To understand that, we went and studied the plasma samples that were obtained in patients who participated in the FLORA study. And we selected patients where we had both the baseline plasma and the post-progression or post-discontinuation plasma samples. There were a total of 91 patients who had these matched samples. And I would point out three key highlights from the study. One is, not one patient developed T790 as a mechanism of resistance, which is good to see because osimertinib not only blocks the common mutations but also blocks the T790M mutation. The second point is, the two common mutations are candidate resistance mechanisms, I would say, we saw, where MET amplification was seen in about 15% of the patients. C797S, which is the secondary or tertiary EGFR mutation, was seen in about 7% of the patients. So if you take the whole group, about 25% of the patients had a candidate resistance mechanism in MET or EGFR pathway alteration. The third point I would make is, there was some concern among some folks that there could be some undue aggressive mechanism of resistance that would emerge when you really suppress the EGFR pathway in a profound manner. The good news is we did not see any aggressive mechanism of resistance come out of this. So clearly these provide new insights. We have some additional work to do. We're doing some work to do tissue biopsies, which will probably give us even more deeper information on resistance.
Great. It's a very interesting analysis.
Thank you.
So now let's go into some immunotherapy. So we're getting some new data and some intriguing activity we're seeing in immunotherapy in non-small cell lung cancer, especially with the IMpower 130 trial. So can you discuss this study and share your perspective on it?
Absolutely. So with immunotherapy becoming part of frontline treatment of non-small cell lung cancer patients, especially for those who don't have the driver mutations, we're learning more and more about new combinations. What we learned today from Dr. Capuzzo is a randomized trial that compared the chemotherapy regimen of carboplatin, nab-paclitaxel, with or without atezolizumab, which is a PD-L1 inhibitor. Now, true to form, this study showed that there was a significant improvement in progression-free survival and overall survival for the combination of chemo with atezolizumab. The hazard ratio for PFS was approximately 0.64. Hazard ratio for survival was approximately 0.78, which are all very exciting. Couple of key points. There was a small group of EGFR mutated patients in this trial, and for those patients, contrary to what had been seen in IMpower 150, there was no benefit for adding immunotherapy with chemotherapy. The second point Dr. Capuzzo made was, in the IMpower 150 study, patients with liver metastases actually did very well with atezo, with carboplatin, paclitaxel, and bevacizumab. In this trial, patients who did not have the liver mets actually did better with atezo and chemo. So this points out that we're still in the learning phase about some of the subsets of patients, and we need to learn more in prospective trials for those patients. But the overall trial was positive, positioning atezolizumab in the non-squamous patients with chemo and PD-L1 inhibition.
Great points. Now, there is a lot of lung cancer data being presented here at this year's meeting. What are some other trials of importance that you'd like to mention?
Sure. When we look at patients with molecular targets, we're beginning to learn more and more about targeted treatments. Larotrectinib, which is a TRAC inhibitor, continues to be exciting. There was some additional follow-up data and more patients reported. TRAC fusions are seen in about 0.5% of lung cancer patients. When they get treatment with larotrectinib, the response rate is over 80%, and the waterfall plot looks very impressive. So I'm very excited about that compound. For patients with MET mutation, we saw new data this year with capmatinib, or INC280, which is a MET inhibitor. And there, patients who are treatment naive, who got this targeted therapy, seem to have response rates of nearly 70%. So we're beginning to have more and more effective therapies for patients with specific driver mutations. And of course, immunotherapy is a big area. We're beginning to learn more and more about how immunotherapy fits in. We heard a trial about blood-based TMB assessment and use of atezolizumab. It was a single-arm trial. It was a little disappointing in the trial that patients with high or low TMB did not have different PFS or overall survival. So TMB is an area where we're beginning to learn, particularly the blood-based TMB. So a lot of exciting information.
Great. Now, reflecting on the data that we have learned here, how would you say that the lung cancer field continues to evolve, and what do you really see kind of going forward?
Right. I think when you look at metastatic lung cancer, I see two key areas thematically. One is targeted therapies for patients with driver mutation. We're getting better and better targeted agents, more targets amenable to targeted therapy. That's the excitement there. In the immunology field, we're seeing movement of immune checkpoint inhibitors to frontline therapy. Now with the Pacific trial, we are using durvalumab in stage 3 unresectable disease, and we're beginning to learn about adjuvant and neoadjuvant settings with immune checkpoint inhibition. So that's also an area where we are seeing benefits to patients. Biomarker-based treatment selection continues to be important for patients with lung cancer.
Great. Thank you so much for sharing your insight today, Dr. Ramalingam. It was really, really great. Appreciate it.
It's my pleasure. Thank you.
Thank you.